webinar events in the learning system for the Personality Disorder Improvement Programme in phase 1. It seems no time at all since we had our launch event, and then all the subsequent workshops and webinars in between. So thanks very much for coming along. Please feel free to introduce yourself in the chat box. We're going to record the event today, and it's going to be available as the other events in the learning system have been on our YouTube, the HIS YouTube channel. Can I have the next slide, please? So that's me. Gordon Hayes, Senior Improvement Advisor. I'm the delivery lead for the PDIP programme in HIS. Next slide, please. For people that are not overly familiar with using HIS, we've got a bit of using Teams rather. We've got a slide explaining how the top bar works. It would be great if people have any questions, if they put them in the chat box. There'll be a number of different points after the different sections of speakers where there'll be opportunities to ask questions. So if we've got them via chat, we can compile them and get some answers for them. Please keep your cameras off and microphones muted. It helps reserve some bandwidth, and that's MS Teams. Can we have the next slide, please? So the webinar will be recorded, and links will be sent out afterwards. Again, next slide, please. Okay, so we are going to hear from members of our team largely today, but we're also delighted to have a couple of guest speakers with us too. So in the PDIP team section, we're going to have an overview of the different elements of the programme, so including the strategic gap analysis, staff engagement survey, speak a wee bit about the recommendations for our phase 2 of this work. And we're delighted to have Professor Carla Sharp from the University of Houston, who's going to provide a presentation at the kind of midway point, and our colleague from SRN Vox and the With Us For Us element of the PDIP programme, Hannah Kane, is going to speak a bit about that work. And then we'll finish off with Rachel King, who's the portfolio lead for the mental health improvement portfolio, who will give some reflections on the PDIP programme and some a bit more information around about where we go next. So that's the agenda. Next slide, please. So I'm delighted to introduce Dr. Aisling McCallion, who has been the social researcher on our programme. I'm just going to speak a wee bit about the staff engagement and evaluation of the learning system events. Over to you, Aisling.
Hi everybody. So I'm just going to give a quick overview here of some of the work that we did around staff engagement and our learning system. So could I get the next slide, please? So 303 staff took part on our online survey, which ran from June until October of 2022. Nurses made up the majority of those who took part, but we had good representation across a wide range of professions. The nurses made up about 48% of the respondents that took part. We also conducted 19 one-to-one interviews with staff from August until October of 2022. Next slide, please. So these are some of our survey outcomes. So staff felt that they had the knowledge, skills and empathy to work well within this area of mental health. But staff also felt that they could also support those with the diagnosis to manage their distress and move on towards recovery. But it was also very clear from our outcomes that staff overwhelmingly felt that there were significant challenges to working within this area and there were limitations within services. Next slide, please. So here's a brief overview of some of the challenges and limitations that we found from our survey outcomes. So one of these was for supporting clients. So this related to effectively managing and establishing a relationship with clients, fostering ownership over recovery and providing wider support. Consistency and team approach was another area. So this was pertaining to lack of agreement and shared understanding between professionals supporting those with the diagnosis. Another thing that came up quite consistently was attitudes towards diagnosis. So this related to negative attitudes among staff and wider service-based stigmatization and misconceptions towards those with the diagnosis. Service-based challenges was also a significant thing that came up within the survey. And this related specifically to lack of specialist and dedicated services, poor countrywide access to interventions, lengthy waiting lists for treatment, as well as staff recruitment and retention. Staff well-being was another area, and this related to the emotional impact of working within this area, staff perceptions over being good enough to deliver care, as well as a lack of well-being and supervision resources for staff shortages, and a lack of training opportunities. Next slide, please. So these are our interview outcomes. So like I said, we conducted 19 interviews with staff across mental health services, and this was to understand barriers towards high quality care. The interviews were mapped to our survey, and these were intended to give a fuller understanding of the issues relating to services as well as staff experiences. So the main themes that we identified from the interviews mapped well to the survey outcomes, and these related specifically to issues around diagnosis and diagnostic language. And this was felt to be particularly problematic, even though there wasn't a good sense of agreement over what sort of language would be better placed, but there was a feeling that there needs to be more scrutiny given to this area. Equitable access to training for staff across different professional groups and across services was another thing that came up significantly within the interviews, as well as stretch on staff and managing relationships. This pertained to managing professional relationships as well as relationships with clients. And service design was a very specific thing that was mentioned within the interviews. So again, this related back to dedicated services, access to treatment, staffing issues, and wait lists, as well as practices around disengagement and discharge for clients. Next slide, please. So this is a brief overview slide for our learning system evaluation. So you can see that we had significant interest and engagement. We had really good levels of attendance, and we had really good engagement right across different social media platforms. Next slide, please. So what we found from our evaluation of the learning system, we had considerable interest and significant numbers attending each event, but we also found that those who attended these events felt that the knowledge and understanding that they gained, or that they gained significant levels of knowledge and understanding around specific areas pertaining to this area. So this was specifically around treatment, diagnosis, areas around underserved and overlooked, stigma, and lived experience. Next slide, please. We also found that people who attended reported that they saw significant impact for themselves, both professionally and personally, going forward from the knowledge and the understanding that they gained from attending the learning system. That's a very, very brief overview of some of the work that I've done. We have a more comprehensive commentary relating to the staff outcomes, the learning system, as well as the other areas that we worked upon on 2022 and 2023 and our final report. So that's my contribution. And thank you for listening. Yeah, Andy, I see your hand up there.
I was only trying to clap for you, Aisling. Sorry, it was a mistake.
Thank you.
That's great. Thanks very much, Aisling. Okay, so and it's over to Andy Williams and Michelle Veldman at our clinical leads for the programme.
Thanks, Gordon. Thank you very much. Thank you. That introduces us. So you can see my colleague Michelle is on the screen as well. So Michelle and I have had the privilege of being the clinical leads for this personality disorder improvement programme, and we're just going to cover a little bit about the one component of the programme, which was to carry out the strategic gap analysis, which was really looking at all areas of Scotland and visiting the health boards and associated HSCPs. Can you put up the next slide, please? I just wanted at this stage of the day to just make a note about language. I know Aisling's just referred to that actually in some of the learning from people around Scotland. Just to kind of note that we know that there are different views around the terminology of personality disorder. We recognise that there's different views about language. And I guess just to highlight that our aim is always to respect these differences whilst getting on with the work, the really important work of trying to work to improve services for people with who might meet this diagnosis. So we're respectful that there are different views about this, but at the same time, we're using the language of personality disorder throughout today's presentation. So can you put up the next one, please? So just a quick scene setting about what led to the Personality Disorder Improvement Programme sort of setting off and how the Scottish Government came to commission this piece of work. In my lifetime, there's been a number of different reports throughout the UK and in Scotland, all sort of highlighting issues around care for people with this diagnosis, that there are gaps, that there are problems, that there are issues to be addressed. And I think it was good timing that two particular reports in 2018 came out in the same year, one by the Royal College of Psychiatrists that I was a bit involved with. And really the message from that report was that there should be parity of esteem. There should be at least as good services for people with this diagnosis within mental health as with any other mental health diagnosis. It should not be different. And fortunately, in the same year, there was a Mental Welfare Commission report around borderline personality disorder in Scotland from the perspective of lived experience, families, carers, and health workers. And a quote from that is that they said that we present a picture of people's varying experiences in being given this diagnosis and the therapies and supports that differ widely across Scotland and the challenges in being supported either in crisis or when trying to stay well. So I think all of this together helped to make the push towards getting this recognised in the programme for government and the commissioning of this piece of work. Next slide, please. And Aisling has just talked you through actually two of the core components of the programme, the learning system and the staff engagement. And as she said, more details are available in the full report. And the bit that Michelle and I are going to talk to is the top right-hand corner of that circle, the strategic gap analysis, which is the programme that we had over the course of the last year to visit all of the 14 NHS Scotland boards and ask really a detailed set of quite probing questions of all of those boards about the way that they provide services. What we didn't get was an actual visit to the Highlands and Islands of Scotland because of COVID, so it was all done virtually. But I think the finding in bold there that one of the main things that struck us through the course of this work is the level of engagement and interest was really high across professional groups, across third sector and staff groups. And I think that's a finding in itself, just the interest and the engagement with this whole programme. I'm going to pass over to Michelle to take you through some of the detail.
Thanks, Andy. So I'm going to elaborate a little bit on the strategic gap analysis along three themes, just to where we try to theme together having spoken to all 14 boards and local authorities in Scotland, the opportunities that we can see that a programme or a phase 2 can continue to work with. Next slide, please. So what we found, the first theme with our strategic gap analysis is systems, around systems in boards, and how we saw numerous pockets of really good, effective work. People talked about their pathways or attempts at pathways, therapeutic intervention developments, and also work with lived experience. What we saw with our colleagues, with our visits, very busy colleagues, our meetings, it was always hard to get meetings in the diary just because people are very busy. And then we had a whole lot of people around the table to hear about their experiences. around service developments for people with personality disorders. And there was always a high level thinking and awareness, real evidence of that. Even if things weren't implemented, there weren't always resources and time to implement things. Of course, the pandemic had a significant effect in some boards more than others, how things couldn't be implemented and how plans had to be moved forward, and also what challenges came with that and opportunities. We definitely saw some disparities between health boards. So boards were very different in their developments. Of course, some of that can be totally explained by rural versus urban boards and other reasons, and differences between the HACPs within the same board. The systems are, we could see evidence of systems really being affected by the way finances were organized, that it was difficult, maybe competitive, sort of fighting for funds, and lack of ring-fenced budgets definitely affected service development. And also how the other thing that was very inspiring was how there was some sense of sharing good practice, some cross-fertilization, and that was in the absence of a more formal learning network. Next slide, please. The second thing was around staff, just the impact on staffing and the stretch of workforce, really in the face of high volume work, high complexity of work. We definitely saw evidence of senior clinicians taking the lead in making things work, and when the organization was behind them, definitely with effective leadership roles. We saw that issues around access and sustainability of how training was rolled out and how that was further developed, and also the equity of access to training. All these things were important to staff and definitely run parallel with some of the evidence that Aisling found in her staff surveys. With people with lived experience, boards talked about all having intentions and plans to engage people with improvement work and redesign work. There were several boards that talked about how lived experience have helped to contribute to development of training programs. And everywhere there was a sense of the importance and value of peer workers, but that's they weren't examples of people being employed yet, but some progress with volunteers. Next slide, please. So what good looks like, Andy and I thought to maybe talk a tiny bit in the short space of time we have here about examples of this. Overall, we got a sense that there wasn't a single model as an example for a pathway, but the following points were important. Andy, I hand over to you for the first point.
Yep. So yeah, we just come up with the examples that stayed in our mind, I think, from different health boards that we visited. So please, if you're from a health board that we don't mention, don't feel that we haven't listened and that you're not included in the report. We're just drawing out a few examples just for the sake of to illustrate this today. So I guess around strategic support and vision, Highland stands out to us as one of the most long-established integrated care pathways in Scotland, and I think one of the most borrowed from in terms of cross-fertilisation, where there's a real comprehensive and clear pathway which is well embedded into services because it's been longer established than some of the others that are at an earlier stage. There's underlying principles that sit beneath it. It's a phase-based approach with step-matched care and a number of different therapeutic modalities, and it includes things like a co-produced coping and succeeding day service. So there's many elements to the pathway in Highland that have been looked at and borrowed from by other parts of Scotland. And I think it just stands out as what can be achieved with a sort of a level of vision and clarity about the whole picture of how services should look in an area that's been well achieved. Michelle,
Thanks for that. The second point of what good looks like to us, having listened to everybody, was just that different interventions are available for different levels of severity. Different boards several boards talked about stepped and or matched care approach. And we could see how people were working with all that complexity of the diagnostic issue around people with personality disorders, that some boards decided to combine personality disorder and complex trauma pathways, and how carefully people were thinking about what interventions to develop where. The other thing there was also the timing of what interventions. So, for example, where general emotional regulation interventions are required, or where maybe specific trauma-specific interventions were required. The boards had talked specifically about it, although it's not an exhaustive list, were West Lothian have definitely thought about different levels of intervention for these things. We've heard Forth Valley talking about it, and Highlands intervention, that pathway that Andy just mentioned, was also a great example of that. Just one quick thing about the several interventions, the ones that we heard about the most, and that's by definitely not the only interventions, were safety and stabilization, decider skills, survive and thrive, steps, and DBT and MBT. Just for people who are interested in the details.
And moving on to the lived experience example, I think one of the nice examples we heard about in one of our webinars was the joint work between NHS Lanarkshire and the Scottish Recovery Network. And we've published that as one of our case studies, so that will be available along with the final report if people want some more information. I think it's a good learning case study for other boards to maybe use and work from, using some innovative engagement methods to move from consultation to co-design. So I won't say more about it because, like I say, we published that as one of our case studies, but there's lots of useful information and tools there to think about how to work towards using the lived experience voice in that more co-design model. Back to you, Michelle.
Yes, and our fourth point is access to relevant staff training, and Greater Glasgow and Clyde has given us an example of coordinated clinical care, one-day staff training pack that's been rolled out or in the process of being rolled out to adult mental health staff. And again, that was our second case study, so people can read more about the details around the development of that pack.
And lastly, for us, just a note on the idea of coordination between different elements of a pathway and different professional groups. I think one of the standout kind of memories I have of the visit with NHS Orkney, very rural and remote part of Scotland, was both the challenges of coordinating, but also some of and the logistics of it, but also some of the successes about how to coordinate between different groups that they've managed. The challenges include things like geography, and a very small staff resource. So the logistics of how to facilitate crisis care with a very small number of staff, or to manage things like patient transfer when air ambulances aren't able to operate because of weather, and they have to use rail and ferries to help transport patients. So there's definitely challenges for them, but the successes, I suppose, were the sense that in a rural and remote area, people know each other, the interfaces work well. The quote was, "We all get together in a crisis," and people know each other. Police, the wider community, the third sector and health workers were able to work very effectively with the small resource that they had because of those good interfaces and relationships. So I think there's something to be learned from that example. So I hope from that quick run through of some examples, people get a flavour of the, we can't cover the whole of the strategic gap analysis, but we're trying to give you a flavour of what we found, and it'll all be summarised in more detail in the final report. Thank you.
Thanks, guys. Can we have the next slide, please? Right. So a key outcome from phase 1 of PDIP was to draw on the combined knowledge and experience that we gained through the programme and to produce recommendations to deliver improvement activity in a potential phase 2. And some of the sections that the colleagues have outlined have spoke about some aspects of that work, and we're going to hear a wee bit from Hannah from SRN and the With Us, For Us element of the PDIP programme that did a lot of lived engagement, engagement work with people with lived experience, and pulling all of that stuff together into our final report and the recommendations has been an extremely interesting and engaging process. We found, I think Andy had mentioned it earlier on, we've conducted extensive engagement with people with lived experience, the staff that work with them, and health and social care services across the length and breadth of Scotland. And the overwhelming thing was the enthusiasm of people and the generosity of their engagement and giving up of time to work with us to try and identify key areas for us to further develop. What was absolutely clear was across all sectors there's a clear consensus that improvements are essential, and that the people with a diagnosis of personality disorder are a group that really deserve better. So we've identified 3 particular areas to focus the proposed work, and that's lived experience, staff and service development. Believe that there's particularly a great opportunity to enhance communication and discussion between those groups, and particularly recommend that learning from people with lived experience to inform training, service evaluation and development, and also expanding the role of peer support. So we are proposing a 2-year phase 2 programme. Can I have the next slide, please? And we've got a driver diagram here that kind of provides an overview of how we see that working. I think, in particular, if we start at that middle box in the primary driver section, we're hoping to amplify the voice of people with lived experience by commissioning a third sector organisation or organisations to establish a national peer support network. And this would obviously be continuing along some of the work that's been done by the Scottish Personality Disorder Network, and some of the approaches have been taken by our colleagues and With Us, For Us. There's a real appetite for peer support, and also provides a load of other opportunities that can further inform the work of phase 2, including ensuring that people with lived experience are partners in the design and the delivery of education resources, stigma reduction and staff training, but also providing an opportunity to contribute to locality NHS board service evaluation and development. And in terms of the support that PDIP phase 2 would offer to boards, we are proposing that we develop national guidance on the key features of affective personality disorder pathways. Some of those, as mentioned by Andy earlier on. Also, we're looking to support, to offer practical support in city closing the implementation gap by means of working with 3 NHS boards as pathfinder sites, particularly focusing on designing and implementing the kind of practical changes that will help improve pathways for people with a diagnosis of personality disorder, and also taking the learning from that experience, producing implementation guidance and tools that can support spread across all of Scotland. In addition, we heard that there was a a patchy picture round about data collection round about the field of personality disorder. So we are going to develop a national personality disorder measurement plan that would incorporate both quantitative and qualitative data. So looking at staff surveys, links with people with lived experience, linking in with what we're calling here the National Peer Support Network, and also delivering support to NHS boards and data measurement and analysis, and utilising webinars and quality improvement workshops. We also propose commissioning colleagues in Nest to work in partnership with ourselves and the peer support network, clinicians, other stakeholders to produce online learning modules to provide specialist educational resources in relation to personality disorder, along the lines of the approach to the Nest trauma informed modules. And in addition to that, we seeking to continue engagement with the learning system events that have been a particular success, I think, of this programme. So that provides opportunities for the learning system to take a much broader approach than we've been able to do just by our core function in phase 1 was to better understand mainstream services for adult mental health. There's lots of other areas that we would have liked to engage more in during these pieces of work. And the next slide will identify them all a bit more, but I think having the learning system there is a kind of a focal point sitting nationally for clinicians and people with lived experience and a whole range of other stakeholders, is a place where we can share learning, share good experience, and look to collaborate in how we drive the knowledge base round about personality disorder and how best to deliver services going forward. Can I have the next slide, please? So some of the areas that I think are absolutely ripe for considering would be CAMS. I don't need to read them out, you can see them there. I think those are all key areas, and there's probably other areas that are of particular interest to the Scottish Government that we would be able to focus on as well. So that's an overview of our proposals for phase 2. There will be a pause between the phase 1 work and phase 2. Rachel will speak a wee bit more about where we're at in progressing things from phase 1 to phase 2 at the end of the presentation. So that's us. I think, well, that's certainly me. I think this is the point where we can answer any questions. Somebody's asked about and Andy's hopefully already answered the question about the peer support network. Yeah. Family support. I see a question. I think it's a question from Suzanne McKenna. I think absolutely. I think the role of families and carers, I think, are also really important. We're fortunate to have representation from the from carers organisations within our expert reference group, and it's been an area that's certainly been of importance to us within the programme all the way through. Lucy is asking about which 3 health boards will be used. We don't know. I think we would be open to discussions, I think, with anyone. Absolutely, Patty. You're asking a question around about any work planned about tackling stigma. That would absolutely be within the remit of the learning system, the work that we're undertaking with boards, the role or the significantly enhanced role of peer support networks and their engagement with boards and with education. We spoke about the collaboration with NES round about education modules. So stigma would be, I'd imagine, front and centre in a lot of that work. Any other questions? Okay, that's great. So thanks very much. I think that I don't know where we are time-wise, but I'm delighted now to hand over to Carla Sharp. David Carmichael has just asked about the more questions. Everybody that's on the mailing list will be kept in the loop round about all of the stuff that's happening, and we are just finalising the report this week, David, so I would expect that the reports should be available within the next couple of weeks. Okay, so as I was saying, I'm delighted to now hand over to Carla Sharp from the University of Houston, who is, I think, around about 9 o'clock Texas time. So I'm going to hand over to Carla just now. Thanks.
Okay, I hope everybody can see me and hear me now. Thank you very much for introducing me. And I also want to thank Andy for inviting me to talk with you all today. I don't know if you are all aware of the fact that you and the work that's been done in Scotland recently has put Scotland, I would say, in the top 5 for really intentionally taking a thoughtful approach to addressing the challenges that individuals face who are diagnosed with personality disorder. So I just want to congratulate your whole team and also everybody that is online today for your involvement in this process. Just listening to the report, it's really very impressive. And we can learn internationally very much from you. I think you were very lucky that you had governmental support for this initiative, and it shows. So, you know, congratulations, and I'm very glad to sort of talk to you a little bit about an international perspective on personality disorder. I am going to talk also about prevention and early intervention. I think that is the sort of next frontier to try and support people earlier in the progression of the problems, when things are a little bit more malleable, and also when young people are still in a system that we can access more readily. Sometimes it's hard to reach adults who struggle with personality challenges. And so really starting a little bit earlier and doing prevention and early intervention, I think is an important goal at the moment. So I'm going to talk quite a bit about that and see, you know, if you have any questions about that, but anything else that I may talk about. So can I have the next slide, please? All right, so I'm going to start with this point of early intervention and prevention for personality disorder. In 2014, so nearly 10 years ago, the National Education Alliance, NEA-BPD, which is an advocacy group in the United States, got some experts together, about 25 experts who were working in personality disorder, and got them together during the American Psychiatric Association conference and really asked for help in pivoting efforts towards early intervention and prevention. At that time, very few of us have been working in that area, but they got us all together and we came up with a strategy to really address early intervention and prevention. And the reason we needed to do this, can I have the next slide, is because there have been many biases or myths surrounding early intervention and prevention for personality disorder, which has impeded the ability of clinicians to assist these young people And then the typical pathway would end up being a young person who begins to have problems. These are not personality problems, pre-adolescence, but these young people sometimes have problems in anxiety, depression, and sometimes oppositionality before adolescence. As they age into adolescence, some of these problems start to coalesce and become an issue in terms of personality functioning. We use the broader term now for personality challenges, which is really challenges in self and interpersonal functioning rather than personality disorder. But this is what we then see as a sort of onset in adolescence. However, these young people fall through the cracks because there are no services for them. And these are the kind of biases that have pervaded and have impeded these young people getting the help that they need. So the first one of these is that the psychiatric nomenclature, so the DSM and the ICD-11 don't allow for the diagnosis of personality disorder. The second belief is that personality disorder symptoms are normative in adolescence and therefore not particularly symptomatic of personality disturbance. And so clinicians would be reluctant to diagnose personality disorder, thinking that a young person is going to grow out of it. The third one is that the symptoms of personality disorder or BPD are better explained by traditional axis 1 disorders, so depression, anxiety, oppositional behavior, ADHD, things like that. The fourth one has been that personality is still developing, and therefore we can't diagnose a personality disorder in adolescence. And the last one, which clinicians weigh the heaviest, is that because personality disorder is seen as long-lasting and treatment-resistant, there had been in the past, certainly, and this sometimes in some systems still pervade, a sort of therapeutic nihilism about it. And therefore, clinicians don't want to stigmatize a young person with a label of adolescent personality disorder. So I'm just going to very briefly talk through some of the research that have been breaking down these myths over the last 10 and 15 years. I don't have time to go into a lot of detail, but I just want to give you a flavor of that to try and move the emphasis a little bit earlier in the disorder progression. Next slide, please. So this is actually many studies, longitudinal studies. So these are prospective follow-up studies that start to follow up young people, pre-adolescence right through young adulthood. The first one that was done was the Children in the Community study by Patricia Cohen. Since then, there's been several of these sort of prospective follow-up studies. And what these studies show is this sort of light blue line for the development of personality challenges. So what do I mean with that? The development of problems in managing the self in interpersonal relationships and specifically attachment relationships. So what we see normatively is that young people do start having more of these problems in adolescence as expected. A lot of young people then do show a sort of normative decline, and they don't get stuck where that dark blue line is. The young people that we are interested in clinical services are the young people that get stuck. They are the ones that struggle to manage the self in the context of interpersonal relationships, but they don't go on to develop those skills in adolescence. They continue to struggle with this. And of course, these problems get more entrenched as they begin to age into adulthood, and they don't launch at the same time that other young people begin to launch. So what we want to do in our services is really close the gap between the sort of normative decline in these problems that young people have anyway, with the young people that get stuck. And those are the young people that we want to identify. Next slide, please. So over the last 10, 15 years, there's been a whole myriad of validated tools to identify young people who are getting stuck at that dark blue line. There's just a bunch of them. I'm not going to go through them, but anybody who's interested in obtaining some of these tools, please write to me and I will help you find these tools. The next slide, please. This is just a continued list of these validated tools. You may have noticed in the columns it says internal consistency, interrate reliability, factors, and then sensitivity and specificity for identifying young people who actually meet clinical threshold. These are all of the psychometric properties of these measures that have been developed and validated. So we do have the tools identifying these young people who are at this sort of dark blue line, so that we can begin helping and supporting them in their identity and personality development, but also helping their families to provide the scaffolding that these young people need. Next slide, please. When we do identify these young people, we are better at preventing the long-term outcomes of these personality challenges in young people. And so what you see here, I know it's a super busy slide, but what you see here, a dark blue line and a light blue line. The dark blue line are young people who at age 12 were asked these questions of challenges in self and interpersonal functioning. And they were then followed up 10 years later. It's a very large sample. You can see that across the board, there's poor mental health outcomes, poor functional outcomes, adolescent victimization across all of these domains and their subdomains. These young people just struggle much more than other people. And so, again, making the argument that we want to prevent that from happening. We want to move the dark bars closer to the light blue bars of young people, and we want them to get back to that light blue line. But for that, they do need the appropriate intervention. So what typically happens with these young people, they get 3 or 4 diagnoses by the time they're 12, 13. They are on a bunch of medications, certainly in the US, where people are very quick to prescribe. So, 3 to 4 medications. People think they have bipolar disorder, they get antipsychotics. People think they have ADHD and they get medication for ADHD. And of course, then they have the typical depression and anxiety medications as well. And so at no point do they get the right treatment that actually scaffolds self and interpersonal functioning. And there is no medication for self and interpersonal functioning. It has to happen through the right kind of psychotherapy for these young people. So, the stakes are high. I hope some of you had time to just read through some of those questions that one can ask at age 12 that can predict these poor outcomes for young people 10 years later. Next slide, please. In this slide, I just demonstrate just from our work, when young people do get help, they get better. So these are young people that received inpatient care at the Menninger Clinic, where we have done a lot of our research. And you do see this decline at 18 months. This mirrors the data for adults. When people with personality challenges get help, they get better, the appropriate help. It's not this entrenched, persistent disorder. It's like depression and anxiety. We don't therefore have to be scared of it, and we don't have to be scared of naming it. It's just a problem in another domain of function, which is self and interpersonal function. When you get the right treatment for it, you get better. So the therapeutic nihilism that has made us reluctant to give a diagnosis and help people get the right help is probably not warranted. Next slide, please. So just to recap, the psychiatric nomenclature does allow for the diagnosis of personality disorder in adolescents. Both the DSM and the ICD-11 allow diagnosis for personality disorder in adolescents. While certain features of personality pathology are normative, some young people do not grow out of symptoms, and features are then symptomatic of personality disturbance. The symptoms of personality pathology are not better explained by traditional Axis 1 disorders. And then what we have found is that personality functioning is as stable in young people as it is in adulthood. So that idea that personality becomes more stable, or that you wake up on your 19th birthday and then you have a personality, but at your 17th or 15th birthday, you don't have a person, those personality traits are actually stable across development. We used to think they're not, but now we know from these prospective studies that they are. And personality challenges do improve in response to treatment. And I will stand still with some of the voices of people with lived experience around this issue shortly. Next slide. So as Andy said earlier on, there, especially in the UK, has been a huge concern about the term personality disorder. There was a special issue in child and adolescent mental health that talked about this. We wrote a commentary on this and tried to make a case that personality functioning doesn't have to be, you know, Andrew Channon used to talk about the diagnosis that dare not say its name, like Voldemort, you know, and we don't have to demonize personality functioning and personality disorder in that way. It just denotes not who a person is, but how a person manages self in the context of interpersonal functioning. So if you want to read more about that, you can go ahead and I think it is freely available. Next slide, please. And we also in 2021 put together a special issue in Current Opinion in Psychology, which is also freely available. It's an open access journal. Where we invited Oselin Balterzin. She is a person with lived experience who does a lot of advocacy work now for early intervention and prevention. And this is what she says: striking a balance between care and stigma remains a key challenge in this area. Patients, unlike some clinicians, accept the personality disorder diagnosis positively as it continues to identify disease rather than negative aspects of themselves. Moreover, delay in treatment increases the likelihood of a vicious cycle of functional impairment, disability, and therapeutic nihilism. Thus, late intervention and the gap between research and clinical practice can have deleterious effects on individual, social, and society levels. I'm not a huge fan of disease. I think we can operationalize this, or the word disease, we can operationalize this just in terms of what personality does, rather than what personality is. Next slide, please. So in this same special issue, we articulated, yes, we have made all these gains in prevention and early intervention. We know that it's valid in young people. We can diagnose it, we can assess it, we can treat it. What we now need to do is exactly what you have began to do in Scotland, and that is moving from description to action. How do we then give people the services they need? Next slide, please. And here in that special issue are two papers that really lay out the barriers to care for adolescents with personality disorder. Andrew Channon has also articulated this very nicely also in the special issue, 5 failures and 5 challenges for prevention and early intervention. And the next slide, please. And what we talk about there, both Andrew's paper and our paper, really talks about that in all these levels of aspects of access to care: approachability, acceptability, availability, affordability, appropriateness, on the side of the service provision, and on the side of the client, ability to perceive that they have a problem, ability to seek help, ability to reach someone that can help them, ability to pay, and the ability to engage. On all of those levels, young people and their families still have problems of access to care. And so that's really the next frontier for all of us, is to try and move the knowledge that have been gained over the last 10, 15 years into actual practice. Next slide, please. This is a paper that we just published, or that came out just this year, by the board of the International Society for the Study of Personality Disorders, really where we surveyed people that work in personality disorder services or personality disorder research context. And we tried to get a sense of some of the attitudes, clinical practices, and perceived advocacy needs of professionals with interest in personality disorders. And next slide, please. And you can see here that people that work in personality disorder research really do feel that there is a lot of advocacy work still needed to get help for young people and adults. Same rates for young people and adults, to give them access to care. So this was on a 7-point scale. If you look at the mean, the average for adults, you see 6 for patient needs, service availability and accessibility. They need that. 6, insurance coverage. They need insurance coverage. Funding for research is needed. Promoting utility of the PD diagnosis is needed for both adults and adolescents. On the 7-point scale, these professionals felt that this is what we need to do, and we need to advocate for these aspects, for patient needs, for service availability, accessibility, insurance coverage, funding for research, and promoting the utility of personality disorder research. Next slide. Brings us to the end, and just thank you very much for the opportunity to be able to talk with you. And again, you are doing what we all are trying to do, which is moving the knowledge into clinical practice and translating it so that individuals who need this help get the right and appropriate help at the right time. So I'll end with that and open up for questions. Thank you.
Suzanne, I think you've put your hand up to ask a question. So we normally have something in the chat box, but don't think there's a question in the chat box just now. So please put your mic on and ask away.
Apologies, that was an error.
Well, you need to ask a question now. No, joking. Okay. Any other questions for Carla? Andy?
Not exactly a question, but I just wanted to thank you for that. It felt very inspiring, actually, to be reminded that these things are not mutually exclusive, thinking about early intervention and thinking about good services for adults. We have to be attending to both. And it's just a really helpful reminder about the battle with that therapeutic nihilism, the kind of myths and the attitudes that it's really helpful to hear that from you as well, just to back up the work that we've been trying to do to maintain the positivity of attending to all of these things and trying to move things forward. We need to widen our scope. We need to think about prevention and early intervention alongside continuing to improve services for adults that have not managed to leave the dark blue line.
Well, thank you, Andy. You're absolutely right, and I think clinicians can lead the way in destigmatizing personality disorder. You know, I think if we are not whispering it to our colleagues and not putting it in the chart, but sort of quietly thinking, I think this is personality disorder, but I'm not going to say it, that is making it a stigmatized disorder. If we say, listen, you struggle to hold on to yourself when you interact with others. This is something we can fix. This is something you can practice. This is something you can work on. We know people get better when you start working on this. That if clinicians take the lead, I think the public will follow. They are looking up to clinicians to take the lead in this and say, you know, there's nothing special about this. Some people have problem with their mood. Some people have problem, you know, controlling their behavior sitting still. Some people have trouble with managing alcohol or substance use, and some people struggle to hold on to themselves in the context of an interaction. And this is something that we can practice and learn. And so thank you, Andy. I hope that we are, you know, on the way to a new chapter in all of this.
So some of those points that you were just making there, Carla, I think link into the first of our questions from attendees. So Kate Humphreys asks, do you have any thoughts on the term personality disorder? I'm sure you do. And whether this needs to change. Many argue that the term is harmful in itself.
Yeah, I am very aware of the stigma attached to personality. And you know what I think happened is when, you know, the word personality has been around for centuries. It means a mask. And what it really means is that we construct actively a sense of who we are as people. And this process begins in adolescence. So what we do, in adolescence, we suddenly have the metacognitive capacity, the abstract thinking, if you remember Piaget, we have the abstract thinking to begin putting together the pieces of the puzzle of who we are as people. And that's what personality is. That's why we call it a mask. This mask that we build about who we are, you know, is very complex. We adjust it for the context that we are in. We manage this mask, this personality, depending on our developmental phase and depending on the demands that the environment place on us. So that's really what personality meant all along, since the ancient times. What happened, I think, in the 1950s is we moved to a trait view of personality, and we began saying that personality is only your dispositional traits, what you are born with. And that's actually not the case. We forgot that we are actually actively building a sense of who we are as people. And the trait perspective began to sort of dominate our understanding of personality pathology. And in that sense, it is stigmatizing, because if we say personality is only dispositional traits, it is stigmatizing, because then we saying to someone, you are wrong as a person. And I fully agree. That is just not okay. And it's also not a helpful, clinically productive way to move forward. But if we do see personality as it was originally intended, that it is the process of building a sense of who you are and then negotiating that sense of who you are in the context of interpersonal relationships, then I don't think personality per se, the word, is stigmatizing. So I think if we can move back to what personality really was meant from the beginning and really say traits are not all who you are. Yes, we are all born with particular dispositions. I am emotionally sensitive too, and that makes me a good clinician. You know, so emotional sensitivity in itself is not pathological. What happens is if I can't manage my emotional sensitivity, and if I build a picture of myself as defective because of my emotional sensitivity, rather as someone that can employ that for a productive purpose, you know, then I'm in the field. So I think we can do some work in changing the meaning of personality, and then it really doesn't matter that we, you know, use what, it doesn't matter what word we use. So that's my answer on that.
Thanks very much. Next question is from Rachel King. Interested in how long it takes to become practice. Touched on it a couple of times. Any thoughts?
Say again. Interested in how long it takes to
become practice, to become
knowledge,
part of practice.
knowledge to become practice.
Yeah. You know, in personality disorder, I want to make sure I understand the question.
Rachel.
Yeah.
What do you mean?
I was really interested. A couple of times you touched on that we know things and we have a body of evidence, but we don't see that in practice or in service. And I was just wondering about your thoughts about that, particularly in this area where there's stigma around knowledge into practice.
Well, it's the holy grail, Rachel. It's you know, some people think it takes 10 years. What you are doing, this is why I'm so excited about what you are doing. What you are doing is exactly that. It is moving it, and we kind of have to be a broken record, and we have to just actively, you know, disseminate the knowledge. Some people say it takes 10 years. Of course, it gets there are ways that path can be interrupted. I do think, you know, at the moment, the worry about the stigma and the word personality is sort of moving the focus away from the treatment that people need, and you know, potentially slowing us down in getting the information out there. So, you know, I don't know how long it takes. It is the work that you do that is moving us quicker along that path. And there are pockets of this in the world. You guys are now a pocket. Denmark has a pocket. The Netherlands has a pocket. Australia has a pocket. In the US, it's sort of dispersed. Unfortunately, we don't have a central healthcare, which I would love to have in the US, but we don't have that. So it's very difficult to sort of transform services. But yeah, if all of you continue to help address these biases, I think we will move the needle.
That's great. Next question is from Richard Taylor, who says that transitions are a problem between adolescent and adult services. Is there a place for a single service between 14 to 21, for example?
Yes.
The gap.
Yes.
Oh, okay,
Sorry.
that's great.
I'm
We've got
so
lots of
excited.
questions, concise answers. We love them.
I'm so excited by that question, because this is absolutely what's needed, and I would actually argue until 25. You know, our brains are only fully developed until 25. We really have a better sense of who we are only by 25. And I think if we can get services extended and not interrupt them at 18, it's going to be much better for young people. It's going to be much better for families. So absolutely, you guys that seem to have more impact and working closer with your government than us here in the US, you know, it'll be amazing if services can start to transition. In Australia, they are moving towards this, you know, I know it's going to be very good for young people. So great question, spot on, absolutely.
I'm getting back channel reminders that we're way over time, but I'm going to, I think, ask one more question. In fact, no, I've been told I can't. Thanks so much. All of the other questions that are there, Carla, we'll compile them, and we can maybe get some answers, and we'll send them in our mail out to everyone that's here. So that was a fascinating presentation, Carla, and I think we could probably talk for the rest of the day around about the points that you've made and the approach that we're trying to take here in Scotland. But I think it's certainly very reassuring for our team to hear that the work that we're doing is pioneering, as you've described it. So that's fantastic. Thanks very much, Carla.
Thank you very much, and I hope we can stay. I know I'll stay in touch with Andy to continue to be up to date with what you all do. It's fabulous. So just congratulations and thank you for having me today.
Thanks, Carla. So I think next I'm going to hand over to Hannah Kane from Scottish Recovery Network, who's going to talk a bit about the With Us, For Us element of our programme. Over to you, Hannah.
Thanks, Gordon. So, hi everyone, I'm Hannah. I'm one of the project coordinators for Scottish Recovery Network, and I'm here today just to give you a super brief overview, I'm conscious of time, of With Us, For Us. This is the lived experience engagement project that we've done with Vox Scotland for the PDIP. Next slide, please. So I want to start by taking you through the key stages of the project. So the first step was for us to reach out to the community and learn from them on how to best get people involved with the work that we were doing. We also completed a lived experience literature review, and we established a lived experience project group, which I'm going to chat a wee bit more about later. However, they were really key in helping us to plan and deliver the project while keeping lived experience at the heart. Moving on to the second stage, this was all around having conversations. So we pulled together everything that we learned from the first stage and just began having conversations with people. We done this through online conversation cafe type events. We had one-to-one conversations. We done an online survey, and we also had organisations engaging with their members and then feeding back. And it was really loud and clear that giving people options on how they shared their views was really key to getting people involved and feeling like their experience matters. And then at the final stage, we looked at the key themes that emerged from the conversations and developed them a wee bit further to look at what would make things better for people. So we created proposals for change to improve services and support. And we're also in the process of developing some creative outputs, but I'll chat more about these later. Next slide, please. So from the conversations, many people shared their concerns about current services. People have experienced a lot of stigma and discrimination, a lack of empathy and compassion, and feel like their diagnosis negatively affects the way that people treat them. There were also issues around the process of actually receiving the diagnosis, with many people sharing that they felt excluded from the process and that it was done in secret. However, a lot of people were aware that this wasn't just solely about staff themselves. They recognised that there were bigger issues in the way that the system operates. There's our workforce that just cannot meet the needs of people accessing services, and there's a lack of understanding around trauma and how it impacts on people's behaviours. These seem to be the main issues that were causing, this lack of empathy and compassion. And I wanted to share a quote from one of our events that I found really poignant. It's the system that is broken. You can have the best staff in the world, but with a broken system, they cannot help. Next slide, please. So once we knew what current services were looking like, we started to talk about what great services would be doing. And a large focus of the discussions was around building good relationships with people working in services. And through having these relationships, people can develop trust, and that is needed to embrace new ways of thinking and adopt new coping strategies. Next, we spoke about how great services would be compassionate. People want support to understand and process their emotions and behaviours instead of being turned away as a result of those behaviours. Compassion from clinicians will help people feel safer when they're accessing support, and particularly when they're receiving a diagnosis. And then finally, for this section, we spoke about how great services would offer a flexible approach. People told us that they want their support to feel more like a journey and then less like sitting on a waiting list to get treatment with little or no choice on what you get. Next slide, please. So following this, we then spoke about what actually needs to change in order for us to achieve these great services. So to start off, we want to move away from services just being trauma informed and having a basic understanding of trauma, and instead move towards being trauma responsive, so they know how to actually support people living with trauma. And that would involve a big focus on safety and collaboration, and also trustworthiness and transparency, particularly around receiving a diagnosis and planning care together. Next, we spoke about a whole person, whole systems approach. So taking this approach means that people would be connected to other services who can provide financial, social and emotional support. We would look to take a more holistic approach to offering people treatment options, moving away from just fixing people and instead supporting them to live well and be accepted, and that should be decided by them, not clinicians. Considerations would also be made for family, friends and carers, who are a really important part of the whole system, whole person approach, but they're quite often overlooked. And then lastly, we spoke about the power of peer support. Connecting with others with similar experiences is really important to people and benefits their recovery. And with peer support, it's a safe space and there's help to understand yourself, and it helps people to develop strategies and tools that are needed to stay well. Next slide, please. So from the co-design events, we then created 4 proposals for change. The first one focused on peer-led support, and there were 2 key areas where people identified peer support could really make a difference. That would be peer practitioners within services and peer-led support groups in the community. So within services, there could be more investment in peer roles, such as peer practitioners who could be supporting people before, during and after therapies or therapeutic courses. And within the community, we want to see investment in capacity building for local peer support groups and training for peer group facilitators. The next proposal was to have whole person, whole system care pathways. So this type of care pathway would be flexible and holistic. It means that people would be offered both clinical and community-based support in the same care package. People would be able to collaborate on the development of their care pathway and be full decision makers on their journey. The next proposal was around a new approach to crisis support. So we really need to rethink the way that current crisis support is offered to people living with trauma, because the current picture is one that often triggers and re-traumatises people. So with that in mind, we looked at a community-based approach to crisis support, which would be a suitable alternative, because the research does show that non-medical approaches to distress are effective. And this approach would offer flexibility and consistent support that will promote recovery and well-being for people who are living with trauma. And then the last proposal that we have is to implement training that is both co-designed and co-delivered by people with lived experience. So the comprehensive training would look to increase staff's understanding of trauma and the way that people present when they're in crisis. And the main goal of the training would be to shift the stigmatising attitudes and also increase compassion towards people who are living with trauma or have got a diagnosis of personality disorder. And part of that training would also look at staff wellbeing, because we need to address the issues around compassion fatigue that we know is happening too often in our services. Next slide, please. So throughout the project, we've been guided by our lived experience project group, and on a personal note, this has absolutely been my favourite part of the project, but overall they've just been key to the success. So we were really keen that we didn't want to just extract people's experiences. Instead, we wanted this to be a mutually beneficial relationship. So we offered learning opportunities for the group. We met every fortnight online, and they've been involved in the planning and delivering the conversation cafe sessions. They've helped us to interpret the report findings. We both, the group and the Scottish Recovery Network team, done the photo voice training together, and they have played a huge role in developing the more creative outputs of the project. And we have learned so much from this group. I honestly cannot sing their praises enough. We're writing up some of our own reflections, as well as the group's learning and advice, which will be shared alongside the report. And I've popped a few quotes on the slides, which you'll get after the session, but I just wanted to share one that's been a really standout point for me. Putting the human element to it. It's part of a bigger project, but this group has brought the human element to it. And I think that one word sums it up, human. It's the group have played such a vital role in this project, especially since so many people we spoke to said that they felt more like a diagnosis rather than a human. So it really was important to have that group bring the human element to the work. Next slide, please. So I'm just conscious of time. I'm going to briefly run through some of the outputs that we're aiming to launch in May or June, just depending on when the other PDIP report goes out. So we've created a full project report that goes into depth about the key themes and the conversations that we had. And then we've also got a kind of quicker summary report. Using the learning from the photo voice training that we done, the Lived Experience Project Group have developed a storytelling with photography booklet to show the reality of living with trauma. We also have a practice learning resource for organisations and services who support people living with trauma and or a diagnosis of personality disorder. So it's a reflective tool using feedback and advice from people with lived experience. And then finally, we're at the editing stage of producing a short animation where the Lived Experience Project Group are sharing their key messages from the report. Next slide, please. So that was my super quick whistle-stop tour of With Us For Us. Thank you for listening. As I said, once the report's launched, there'll be a lot more detail included in that, and you can find out more about the project when it's all launched. I'll now hand back over to Gordon.
Thanks, Hannah. That was great. Top marks for rattling through all of that in a short space of time.
The Glaswegian, we can speak pretty fast.
Well, and we had the woman from Derry to start off as well. We can get on through it quite quick. So if anybody does have any questions, please put them in the chat box. We've got a couple of observations so far. Just people talking about, excellent work. That the importance of having that people, human beings with lived experience at the heart, and how we can improve and have more higher quality and effective services.
Absolutely.
And support. Does anyone have any other questions for Hannah? I don't think there are just now. So Hannah, thanks very much for that.
No, thanks for having me.
Okay, cheers. So I'm now going to hand over to Rachel King, who is the portfolio lead for the mental health improvement portfolio, who's going to have some reflections around about PDIP and maybe speak a wee bit about what the next steps are. Over to you, Rachel.
Thanks very much, Gordon. And I didn't type fast enough that time to ask my question. So there's a question for you, Hannah, in the chat from me. But thank you, everyone, for being here today. And thank you to the speakers of today who really brought to life both the programme of work, but also the topic area as well. I think what has been most striking to me throughout the course of the programme is just that we are definitely working in an area of great need, with a lot of energy wrapped around it and great opportunities for change and development. And I think that's what's come out over the last hour and a half as well. It's really clear that we have a knowledge and understanding about what would help. We have a knowledge and understanding about the enthusiasm and the will of people to make a change that will create better outcomes and better services for people, and we have a real understanding about what that might look like. So I did just want to touch on a couple of the things that I think were really amazing from all the amazing things that we've heard this afternoon. I think what's been really clear is that the engagement of local areas couldn't have been better. You know, the strategic gap analysis couldn't have been done without engaging with every board area, every local area at the Health and Social Care Partnership in Scotland. And I think that richness of understanding about what the current context is in Scotland, where the good practice is, and what change might look like has only been possible because of that. We've had real strength in the relationships that have been built. And I think you've seen that today. You know, there's 90 something people here this afternoon, but there's a real strength, both people with lived experience, with carers, with communities, with the third sector, and with statutory sector colleagues right across the whole system. The other thing that's very clear is what we've heard about staff's wish for change, about an understanding of their frustration, about an understanding of the frustration of people themselves and the people within their families and the people who care for and about them. I think the other thing is, as Michelle and Andy picked out before, some of the excellent work that is already happening that we can build on. And I was really struck by what Carla talks about this work puts Scotland in the top 5 of the places that are trying to address the needs of people with personality disorder. And in terms of that, thinking about our understanding and the richness and the depth of knowledge that we have now means that we're in this really strong position to understand what that might look like. And that's partly because of all you here today. It's partly because of all the colleagues across local areas in Scotland. And it's partly because we have an understanding nationally that this is an area that we need to address. So I did just want to touch on, as Gordon has said, about the learning that we have gleaned over the past year has allowed us to put together a hope for a phase 2 of the personality disorder improvement programme. I need to make it clear that we have no current agreement about that is a process that we are going through. Gordon shared with you our ideas about what that would look like, and that's built on the work that you've all heard here today and some of the evidence and some of the relationships that we've built internationally and nationally with people such as Carla and others. We are in conversation and we are going through the process both within our own organisation and with Scottish Government about the phase 2 work. And we will, of course, and I saw that there was a comment in the chat about it earlier, keep you informed about that. So do stay in touch with us if you're interested in the next steps and you're interested in how we might work with local areas and where those local areas might be, which was another question in the chat. But we are hoping and anticipating that there will be a phase 2 for this work later in this calendar year, and we are working towards that being a reality. All your input has helped get there so far. I wanted to end with some thank yous. So thank you to Dr. Carla Sharp, thank you to Hannah Kane, thank you to the other speakers from the team, Aisling and Michelle and Andy and Gordon. Thank you to everyone who's put this day together. Thank you all for attending. But I'd like, if we can, to have the team put their cameras on just now so that we can see them all together as the people who have really put together this piece of work from the outset until now. And I know we've been doing a lot of yellow hands applause, but I would really, really welcome us to give a round of applause to the people who've put together this webinar. A number of other learning events have pulled together that whole piece of work that you saw outlined today, and who are trying to put together the next phase of this work in order to do, as Carla talked about, get knowledge into practice and make us and keep us at that, within that top 5 of places that are trying to address the needs of people who may attract a diagnosis of personality disorder. So that is what I want to say. Thank you very much, team. It's great to have you all involved in this. And thank you everyone for attending today. And I'm going to hand back over to Gordon at this point to close. Thanks very much, everyone.
Thanks for that, Rachel. Well, that's it. That's phase 1. Completed it, mate. As the kids say. It's been a fantastic experience working with all of the people on the team, all of the people out there in the wider systems that we've worked with, and I think, as Carla had outlined, we're in a great place going forward. So thanks very much for everybody's input, and I'm sure we'll meet again. Thanks so much.